Thanks and welcome to this video. I'm Paul McMurrick. I'm the head of the Department of Surgery here at Cabrini Health, and this is Gary Richardson, who's the head of the Department of Oncology here at Cabrini Health. And we're going to be talking today about management strategies for patients with bowel cancer, screening for bowel cancer, and management of patients with metastases during the COVID crisis. Gary, welcome.
Thank you, Paul. So, Paul, let's kick this off. Tell us about screening for bowel cancer during the crisis.
Screening is a difficult and contentious issue at the moment. We're actually breaking people up into two groups. There are those that we'd regard as high risk and those that are low risk. Patients that are having routine surveillance colonoscopy for follow-up of a positive family history, that's a category 2 family history. In other words, they've had a single affected relative under the age of 55 or multiple affected relatives with bowel cancer. Those patients can probably, for the time being, instead of having their 5-yearly scope now, defer it until after the crisis. And currently, in mid-April, we're encouraging people to do exactly that. What we are also encouraging those people to do is to perhaps consider taking a single one-off fecal occult blood test during that period of time. Of course, they also do need assessment to make sure that they're asymptomatic. The whole premise with asymptomatic screening is assuming that the patient has no symptoms. So I think it's important that if you're seeing them as a GP, you need to speak to that patient, ascertain whether they do have any what we'd refer to as symptoms of proximal pathology, whether they've got rectal bleeding, change in bowel habit, unexplained abdominal pain or weight loss. If they have those symptoms, then they should be referred on for assessment. If they don't, they can probably defer their scope till next year. And if they're concerned, they can undertake a fecal occult blood test in the meantime. The more high-risk groups are those patients who've previously had high-risk polyps. In other words, a large polyp greater than 15 millimetres, presence of high-grade dysplasia, or patients who've had piecemeal removal of a polyp in the past. In addition to that group, there are those that are symptomatic, the patient that has either got any of those symptoms of proximal pathology, including bleeding, or patients that have returned a positive fecal occult blood test. Currently, under the guidelines, we don't believe that it's safe to defer investigating those patients, and those patients should proceed with a colonoscopy or at least a discussion with a consultant about the option of colonoscopy. If they're particularly high risk for COVID or they've got concerns about coming in at the moment, again, one could consider the option of covering them with a fecal occult blood test. But I think it's important for people to understand that 17,500 Australians each year will develop bowel cancer. If we were to defer screening of patients at this point in time, and there was upstaging of perhaps 20 to 30% of those patients with bowel cancer, then the loss of life secondary to that process could easily exceed the projected loss of life from the COVID crisis. So all patients that are at high risk should continue with screening. All patients who have a strategy for screening should have that reinforced. Fecal occult blood test can carry over the low risk people until next year. But again, if there's any doubt about the strategy for screening, the most appropriate thing to do is to refer them on to a specialist to discuss that option.
So what do you do if you're a general practitioner and you don't know what to do?
I think the recurrent and important message that we're trying to project is that we're all still here. We're available to talk, to give advice, we're available on the phone, or if it's less urgent, patients can be referred into. But all the consultants at Cabrini and all the major associated public hospitals are still freely available to discuss the options that are available for these patients. If there's any doubt and the patients don't wish to come in, all of us now have telehealth consultation in place, and most of this assessment can be done over the phone. So Gary, once a patient's been diagnosed, they've undergone their colonoscopy and they've got a biopsy positive large bowel cancer, what's the process going to be for management of them during the COVID crisis?
The management really won't change. What happens firstly is that every patient that's newly diagnosed with colorectal cancer is presented at a multidisciplinary meeting which contains specialists in all areas that treat cancer. A decision is then made with regards to the treatment of the patient, whether it's surgery, chemotherapy, radiation therapy. All of those decisions are discussed and a treatment plan is made. We then enact the treatment plan and the appropriate specialists that need to be involved in the patient's management become involved.
So tell me in summary, in a patient who's diagnosed with a colonic cancer without metastatic disease, how would that patient generally be managed?
Initially surgery. Surgery is the only way that you can cure a colorectal cancer. So they will undergo surgery first. Once they've had their surgery, their pathology will be reviewed And there are a number of risk factors that we look at to determine how likely it is that their cancer could recur at some stage in the future. If they have high risk of recurrence, chemotherapy would be recommended. The chemotherapy recommendations have changed over the last couple of years in that a lot of the treatment involves oral therapy and it's not particularly myelosuppressive. So from that point of view, the risk of infection is not particularly high. That doesn't equate across the board in that there will always be a small percentage of people that will get excessive side effects and they will need to be watched closely. But the reality is, if we change the treatment that we give patients at this point because of the infection, it is more likely that they will get a recurrence than they will actually get serious problems from the infection. The recommendations from all our professional bodies are to treat people on their merits and treat them entirely appropriately.
So the situation's slightly different for a patient who's diagnosed with an extraperitoneal rectal cancer, in other words, in the lower two-thirds of the rectum below the peritoneal reflection. If that patient presents with metastases, what's the general management of that patient at the moment?
So the management of a patient with extraperitoneal rectal cancer per se without metastases is usually chemoradiation. The chemotherapy is oral chemotherapy, and radiation is usually not particularly myelosuppressive unless the patient is particularly old. If they have metastatic disease, then you have two issues to deal with, and the main decision-making process relates to what's causing most of the trouble. If the tumour in the bowel is causing most of the trouble, that needs to be dealt with first. If the tumour in the other parts of the body, the liver, lungs, wherever they are far more likely to cause problems, then they'll often have chemotherapy first. Once again, a lot of the treatment is actually oral, so that giving oral therapy reduces the patient's need to come into hospital and therefore potentially reduces the patient's risk of being exposed to COVID-19.
So do you see any change in these protocols now during the COVID crisis?
I don't think there will be changes. I think that the guidelines are very clear. I think that if there are patients that have significant comorbidities or are particularly old, we already make changes to the treatments they receive based on that information. From the point of view of what is occurring at Cabrini, there is strict guidelines around entry into the hospital, around the number of people that can be with patients, and there is already social isolation in both the consulting suites and in the chemotherapy units. So from that point of view, all of these patients are being heavily screened, as the staff are, so we are making it as safe as possible. So Paul, during this crisis, have you had to make any changes with regards to surgery for patients?
Generally speaking, no. There's been some minor changes. For most patients with colon cancer, no, we just still proceed if we're treating with curative intent. As you've mentioned, first modality is surgery, possibly followed by adjuvant chemotherapy. Rectal cancer, there may be some minor changes if patients are at particularly high risk of COVID. At times, we might alter a decision to perform one-stage versus two-stage surgery. We will have the situation with older patients where a complex reconstruction, which may require a diverting stoma and then a subsequent return to theatre. I guess it would be fair to say I've had some conversations with these patients during the crisis, and in many occasions they've opted for the simpler option of a one-stage operation with a stoma. But overall, the implications for surgery are that it's staying exactly the same as it's been. So Gary, you're treating a patient with chemotherapy. They've been diagnosed with stage 3 colorectal cancer and they're post-surgery, or heaven forbid they've got metastatic disease and you're treating them with chemotherapy. And coincidentally now they've been diagnosed with COVID positive disease, or they're being treated as COVID positive. Would that affect your decision making about chemotherapy?
Absolutely. If a patient is diagnosed with COVID-19 or is suspected of COVID-19, then we would defer chemotherapy. If they have COVID-19, chemotherapy would be deferred until they have recovered from the infection and they have tested negative. If they're suspected of COVID-19, they will be sent immediately for testing, and chemotherapy would only recommence once their swabs were negative. Paul, do you think it's likely that there's going to be any change in morbidity or mortality from bowel cancer because of the COVID crisis?
Well, of course, long term we don't really know, and it's difficult to be certain about that at this stage, but there's no indication at the moment that short-term morbidity or post-operative mortality will be affected by the COVID crisis. Firstly, there are very clear precautions being taken at Cabrini to ensure that patients and visitors, when they come in, are screened for the COVID-19 virus. And secondly, we know that we've had in place here for a decade now the colorectal neoplasia database, which incorporates both outcomes from this hospital and from all of the Monash Partners associated hospitals. So we're very carefully monitoring both post-operative morbidity and mortality to make sure that there are no alterations during the COVID crisis. So Gary, in terms of long-term follow-up, the patients that you and I have co-managed over a long period of time that we're seeing in post-operative follow-up, we've regarded them as cured, but they're being surveilled for metastatic disease down the track. Do you see that process changing during the COVID crisis?
The current recommendations are that we use telehealth. All of their investigations can be done as per normal, but the reality is we're trying to reduce their risk of being exposed to the disease. That means not coming to the hospital. That means that we contact them by phone or Skype or Zoom and discuss their results with them and then make their next appointment.
Do you think there's going to be any change to available tests, access to tests because of telehealth?
No, not at all. I think that the tests can be organised exactly the same. They're usually done by our secretarial staff. All of the patients that we've treated to date doing that have had their next investigations ordered and their next appointments made. Whether we need to use telehealth when the next appointments are made will depend on when the crisis ends.
Sure.